So today we are very excited to welcome Dr. Michael Biscaro, who is St. Vincent Charity Medical Center's Chief of Behavioral Health and Addiction Medicine. In this position since January of 2020, Dr. Biscaro serves an integral role in improving access for Rosary Hall detoxification and outpatient programs, inpatient adult and geropsychiatry, and the psychiatric emergency department. He is leading the clinical teams providing behavioral health and addiction services in a transformational effort to create an integrated and expanded continuum of services that really address the holistic needs of patients, which is what we are going to learn more about today. He has served as the VA Northeast Ohio Healthcare System since 2009 in the roles of Program Director and Team Leader for the Psychosocial Rehabilitation and Recovery Center and Clinical Psychologist. And in 2017, Joseph's Home named him as Behavioral Health Director. Also, he consults with various behavioral health programs throughout the community to extend best practices and improve training. He holds a bachelor's degree in psychology from John Carroll University and a master's degree and doctorate in clinical psychology from Xavier University. He completed his internship and postdoctoral residency in clinical psychology at the Louis Stokes Cleveland VA Medical Center. So please welcome Dr. Biscaro to share his innovative and transformational work at St. Vincent.
All right, thank you. Appreciate that introduction, Rachel. Hopefully I can live up to all that. I'm going to go ahead and start to share here. We're good. All right. So I want to thank everybody for joining the lunch hour here today. I hope you don't get too mad at me for giving up your lunch half hour. So I'll try to make this interesting. This is really a great opportunity to speak with you all, to talk about integrated care, something I'm extremely passionate about, have been for quite a while now. Also particularly passionate about, working with people who have serious mental illness and co-occurring addictions, and really talking to you today about really the method and the approach that is evidence-based for this population, and some of the challenges, kind of why we're not there yet, what we've been doing to address the need, especially during this unprecedented and challenging time. For those of you in healthcare, this might be a little bit of a review, but also really an invitation to partner and learn from one another. We are new in this effort to integrate our services. So if there are folks out there that have been doing this for a while, I'm sure we can learn from you. If there are people who are considering doing this, I'm sure there's stuff that you can learn from us. So this is also just looking at it as an invitation and hello, we're out here, and join us. For those of you in the community at large, this will be an opportunity maybe to understand a little bit more about why integrated care is needed, provide a resource and point of reference for what services can look like to meet the needs of folks who have complicated health problems. So I would be remiss if I didn't start out with first explaining a little bit about who we are here at St. Vincent Charity Medical Center. It's important to know, I think, that the Sisters of Charity of St. Augustine have been in the business of doing healthcare for the last 156 years. They've been around for a while. They've been dedicated to and as we are as an organization, dedicated to the healing ministry of Jesus, which is really simply helping, respecting, valuing, and providing care for all of God's people. Our services, though, are for everyone. And our commitment is really to providing quality service and educating future healthcare professionals. So I wanted to put that out there. I also want to kind of just give a snapshot of the behavioral health service line here. For those of you that don't know, we've offered a solid continuum of acute care. And as of recently, the first of this year, probably officially in December, we started offering outpatient services. For us, this is really a historic moment, quite frankly, moving from acute behavioral health care to more complete behavioral health care. We can really meet an individual's needs wherever they are. Obviously, many people know that we have a psychiatric emergency department here, so we can meet acute psychiatric crisis real time. A little bit different than a traditional emergency department where people may be waiting for hours, maybe have to be restrained, wait for medication. We can treat psychiatric crisis real time. We can do the same for acute detoxification. So somebody in acute addiction crisis, they can walk into our emergency department, be evaluated, and be admitted to a Rosary Hall inpatient detoxification unit if that's what they need. Obviously, we also have acute stabilization and treatment services, acute psychiatry. We have a number of beds dedicated to caring for adult and gero, older adults on the inpatient setting. We also have intensive services in Rosary Hall. So many people have probably heard of Rosary Hall. So Rosary Hall inpatient, which is our detox unit that I just spoke about, and then Rosary Hall outpatient services, which is where we can provide intensive outpatient treatment for people with substance use disorders. Now adding to all of that, we have outpatient mental health trauma and wellness services. We've really expanded what we do here, and it's really an exciting time. I also, though, want to take a little bit of time to pause and thank a few people in our organization. Whether they're on or not, I don't know, but I definitely want to thank our hospital CEO, Jan Murphy, our Chief Administrative Officer, Dr. Adnan Tahir, our health system CEO, Tom Strauss, and of course, our congregation and our congregational leaders, Sister Judith Ann Karam. It's their support and commitment to behavioral health, and the significant commitment to behavioral health, which has really allowed us to establish this full continuum and really allowed our expansion to become a reality. I can honestly say that we're not done yet with our growth, innovation, and expansion, but it's at least exciting to be at this point and moving forward. And it's really refreshing to have a leadership in an organization so supportive of such critical life-saving services. We'll talk a little bit about why that is. So obviously, being in the business as long as I have and as long as this organization has, we've really understood that there's a significant problem facing individuals with mental illness and addiction. I think many of us know that people with mental illness and addiction are marginalized, they're stigmatized, they don't often access or attain access to services when they need it most. So what does this do? It certainly results in people dying much sooner than those people who do not have those conditions. The general rule of thumb is around 25 years earlier than those people who do not have those conditions. More than 2/3 of people with mental illness have one or more chronic medical conditions. 1 in 5 experience a co-occurring substance use disorder, and that can really be as high as 50 to 75% for people with more serious and persistent mental illnesses. So schizophrenia spectrum disorders, bipolar disorders, severe major depression, chronic PTSD tend to see a lot higher rates of comorbidity or co-occurrence of substance use disorder in those populations. So what does this do? This usually ends up in people dying from things that are preventable chronic illnesses or complications from those illnesses. So we can and we should do more. If that's not enough, if it's not enough that folks who have these issues have more complication, we're now dealing with a global pandemic and also an opiate epidemic that hasn't gone away. A recent survey from Kaiser Family Foundation found that 4 in 10 adults are now reporting serious symptoms of anxiety or depression. That's up from 1 in 10. 11% of those people are seriously considering suicide in the past month. These differences were more striking in especially our younger adults, 18 to 24. So and then in a 12-month period, the CDC found that there was the highest number of overdoses in May of 2020, around 81,000 folks, overdosing. So I think this has been pretty well established that we know that rates of depression are going up, rates of anxiety are going up, suicidality is going up, and overdoses are going up. So we have a significant problem. there is a solution to addressing this complicated problem, and it's really around integrated care. So integrated care, for those that don't know, is really bringing together the world of medicine, mental health, and addiction. It's a way to sort of bring together all of those things that typically somebody needs. It's an emphasis really on whole person care, bringing the person at the center of both behavioral health care and primary care. It's understanding more completely, what their healthcare goals are, what the plan of care is. It's taking care of their mind, body, and spirit. The emphasis tends to be on people who are more seriously and persistently mentally ill, who have chronic or co-occurring addictions and increased medical complexity. But really, let's face it, I think all of us want people to be thinking of us as people and not just the problem that we come into them with. So really, what's different about integrated care versus traditional care? I think there's a few really sort of clear differences. For one, it moves from more problem focused to being more person-centered. An individual needs to be confident to make changes, whereas I think in traditional care, we assume people have knowledge, we assume they're ready for change, and a lot of times in the population that we work with, people are not always there just yet. In collaborative or integrated or person-centered care, the individual themselves set the agenda. The goals need to be clearly identified by them. Decisions are made collaboratively. Also, in collaborative care, we really understand and offer what's necessary. We understand risk, so stratifying people in terms of their level of risk and deploying services accordingly. We're moving from fee for service to value and measurement-based service. We do this type of care because people with more health complexity are more vulnerable to the challenges of their conditions. They typically require longer-term treatment, whereas most people, I think in the everyday problem-focused world are looking for a quick fix. It doesn't really work like that in this world and with this population. Rehabilitation efforts to improve outcomes are necessary. So working with people over time, impacting multiple systems, providing multiple supports. Typically just a medication is not going to solve the issue here. Things need to be tailored to their issues. One size doesn't fit all. Individuals with multiple health challenges also generally experience a lot more crises, more social challenges, and progress more gradually in treatment. I think those are things that are important to know because there's a cost to not integrating treatment. Because of those things, because of the adjustments that need to be made, because of the needs folks with health complexities have, there's a cost to not bringing treatment together. It's interesting though. I mean, I think we've known in the evidence world, in the world of what is scientifically known to help this population, that integrated treatment is kind of the way to go. The system of care has certainly not caught up. We're doing a lot more of it, but we're certainly not doing enough of it. Again, I think there is a cost to not integrating care. And what is it? We see a lot of cycling through the system. You hear about the revolving door. People that demoralizes the treatment system. You start to hear people use words like, this is a frequent flyer, this person's crazy, this person's an addict or schizophrenic. That leads to staff, problems with staff turnover, retention. That leads to decay of the system. Treatment is less effective because we lose staff. People don't want to come where they don't. People also who are receiving services don't want to go where they're not seen as people. This obviously leads to ongoing illness and death and people not getting well. So I'm not going to leave it like there. I mean, this would be a bad place to stop. The good news is that we know integrated care works. Okay, a study put out by the SAMHSA Center for Integrated Health Solutions. SAMHSA obviously is the authority on many things in mental health and addictions. put together this study that showed of 170 different folks with mental illness that if we integrate care, we can reduce homelessness. So 86 fewer nights homeless, fewer hospitalizations, nights in detox, ER visits. This all equaled about a $2.5 million in savings for this group of individuals. In other words, this saves lives, it reduces costs, and it improves people's quality of life. So if we ask ourselves, why haven't we gotten there yet? What's going on? What's the reason why we're not doing this if it works? I think there's a lot of different reasons. I think stigma and attitudes is one reason. Medical providers understanding the importance of understanding the importance of mental health and how that impacts physical health. Gaining true parity in our system of care. People themselves being willing to seek treatment. That really happens when it's normal to go to a psychologist like me, or a psychiatrist, or a social worker, just as normal it is to go to the doctor when you have a runny nose. We really need to move past this thing that mental health and addiction is some type of a healthcare pariah, and that it's necessary, for wellness and health. Policymakers, we need to make sure that people are setting the right strategies at the policy level. Our public officials, that they're creating funding streams, that they're investing in mental health, just as we invest in cancer research and all other types of medical issues. Have a lot of hope here in Ohio. We certainly have a current administration that's investing a lot. Director Chris and Corcoran and Governor DeWine have certainly been vocal about their support and need for change. Really investing in outreach, prevention, building a continuum of care, the things we know that are necessary to keep people out of the hospital and in their lives. Other things that impact, the ability to provide integrated care, of course, regulatory and billing standards. Those of us in the business know that it can be difficult to provide multiple services on a particular day in the same location. And I think COVID has actually helped open our eyes to some of the lopsided, inefficient billing practices that we've had. It really opened up our ability to provide telehealth and to provide service in different ways and relax some of the rules. And thankfully, I think the genie's out of the bottle. I don't think we're going to go back to some of the kind of archaic ways that we were. So now people will have more access. Now we have some flexibility. So really the time's ripe, I think, to make some advances. Of course, another issue with integrated care is just resources. It can be hard to find the staff to do this, to have people who really understand multiple issues and can treat multiple issues at once, to have the space to do it, to have the record system that you need, the electronic medical record system that you need to track outcomes and to understand what really goes into helping. So in order to accomplish this here, we've really had several key initiatives. We needed to integrate our system of care in every sense of the word. The service line needed to be, the behavioral service line needed to be operating together as one unit. But we really needed more than just acute care. We needed to do more than just admit and discharge people. So expanding to outpatient services, adding remote service capability so we could do telehealth was important. We needed to have more robust and intensive treatment options given the range and complexity of our population. We needed to add peer support staff, people with lived experience to our continuum of care. We now have peers at all levels of care here. They're in every program, on every unit, and can really help people transition from one level of care to the next. We really needed to add to our ability to coordinate care and really help people transition in care. That's, I think, where we lose the more complex population the most, is when they move from one level of care to the next. We needed to establish a panel of providers so we could integrate care, to get the right folks to provide the right care of service, the right care at the right time. We needed to have some direct integration with medicine. For those of you that don't know, we implemented a screening and brief intervention and referral to treatment program. It's called SBIRT. So this is where you go into medicine or you go into medical settings, and in those settings, they identify people who are at risk of mental health or substance use disorders. We also screen for trauma in our medical settings here. We also implemented a medical psych rotation. We have a pretty robust residency program here, and our medical residents all rotate through our mental health areas to provide medical care on our inpatient units. And of course, coordinating and integrating with primary care. Really what all of this has led is to a much more robust, fuller continuum of care. We can offer consistent care coordination and help with care transitions at the right time. We can support and address social determinants of health. This model is intended to keep people out of the most costly, intensive levels of care and living healthier, more productive and meaningful lives. Really in addition to our own investment and the leadership support here too, a lot of this has been made possible by grant making opportunities. We've been really fortunate to have support from the county and the county's opiate settlement. We've been fortunate to get support from funders, folks like the Sisters of Charity Foundation of Cleveland, the Cleveland Foundation, Mount Sinai Foundation, the CPPS Heritage Mission Fund. They've all really helped us do what it is you see before you and establish this continuum of care. Why is this important? Well, it's important because we need to improve client engagement and services. We need to improve care transitions, and we need to improve the health outcomes for those we serve. What I think makes us now a little bit unique is that we really do offer a complete continuum of care here now. And if we don't have the service, we have a partner who can help us attain that for an individual. Being able to help people transition from one level of care to the next is critical. So now that we have this one-stop shop and moved from acute care to complete care, we really can meet people's needs at the right time in the right place. Again, having peer support at all levels of care and expanding our care coordination and navigation efforts. This has been pretty important and I think is a unique service and feature that we offer. Having behavioral health screening in our inpatient and outpatient medical settings, and really having this movement to primary care embedded within our behavioral health care practice, which I'm going to tell you a little bit about. Probably the crown jewel of our expansion here is the integrated care clinic, which is in our medical office building across the street. It's an expanded outpatient area where we offer mental health, trauma and wellness services. Our team there currently offers individual and group psychotherapy, obviously assessment, evidence-based trauma-focused interventions, couples therapy, peer support wellness services, and prescription opioid weaning. These clinicians really understand the entire person's needs. They can connect them to the appropriate treatment modality and type of care that an individual needs. Care plans address a person's goals and objectives that will really help them attain improved mental, physical, and spiritual health. Our clinic's fully remote and able to serve people virtually and in person. The campus here is a robust primary care presence. We have a number of primary care offices on site here. So if individuals need primary care, they can get it, even as close as across the hall. We have access to outpatient psychiatry within our hospital's healthcare center and can connect people with medication management services that a psychiatrist can provide if their needs are more serious than what our nurse practitioner that's in the clinic can provide them. Within the next 6 weeks, our efforts to full integration, I think, are really going to come to fruition. For those with greater health complexity, we are going to offer primary care clinics within the suite. So right within this spot that you're seeing here on the slide. And then we're also going to have psychiatric medication management services in the clinic itself. So it will really truly be that one-stop shop. So you see a pretty cool picture here. Hopefully I'm pretty obvious in the bottom right there. But in the bottom left, not the guy with the camera, is Dr. Spieth, who runs our outpatient Rosary Hall clinic. Back left is Dr. Ted Perrin, who's our co-director, our co-medical director for Rosary Hall and a renowned expert in addiction medicine. And then back right is Dr. William Ajayi, who actually is managing our integrated care clinic. So how is this a little different than others, this clinic? I think one of the things that makes it different is we can attend, people can attend remotely, completely if that's what they need. We can help people who have complicated mental health or co-occurring medical issues. We can assist them in trauma, we can assist them with trauma in an evidence-based way. Our therapists are trained in cognitive processing therapy and prolonged exposure, so we can really address those issues. And I think we all know right now that this is a time when that's needed a lot as people struggle, and especially as our healthcare professionals and those who are on the front lines, dealing with this pandemic. We can facilitate treatment and motivate those who simply don't respond well to traditional treatment approaches. We can treat the whole person and really give them the time, the care, and respect that they deserve. This is how you would access our clinic. We did centralize intake and access here to make it easier for people who need inpatient and outpatient services. You call one number and you press 1 or 2, and we'll get folks access to what and where they need. So I think it's also important to talk a little bit about how we work together to make changes. This is a group that probably is varied. I'm used to talking to a lot of healthcare professionals or people in the business, but we have the community at large here. So how do we work together? I think community leaders can certainly normalize mental health care in their organizations in various spheres of influence, which are probably many and far-reaching. We can offer benefits packages that are inclusive of all conditions. We can support employee wellness and really talk about mental health like you would any other condition in your setting. Health and social service agencies need to work together and alongside the business community. We really need to form partnerships and networks of care. That's really going to be the wave of the future, to have a more coordinated system of care. No one provider is going to do this. Maybe folks think they might, but I think what we've learned over the last year is that we are better together than we are apart. And COVID, like I said, COVID has certainly opened the door for ways to partner, for both organizations who may not normally partner to partner, and do that in a way that just continues to grow. I think this might sound simple, but understanding available resources. I think all of us need to take ownership as to what's available to get our own or other people's health needs met. If you don't know, you should ask. I mean, how many people right now here could tell someone they know where to go if they needed help? If they came to you and they said, this is what's going on, where do I go? Well, now I hope you can tell them there's at least one place. St. Vincent's, this great little hospital at downtown Cleveland, they can really help you get most of your needs met. So I probably went over my time a little bit, but.
Dr. Biscaro, that is absolutely okay. We do have time for a couple of quick questions. And if you are okay, I can send a couple of follow-up questions afterwards and we can share that with the group in our follow-up email.
Sure. Absolutely.
So at this time, are pediatric patients included in the treatment services, or are there any plans to expand to pediatrics?
Currently, they are not. To say, though, that that's not an interest of mine, I'd be completely lying. I think, though, again, healthy adults equals healthy families, but really understanding kind of that two-gen strategy, taking care of the whole family, really integrated care and person-centered care is about taking care of the person, their family, the community around them, and the caregivers who take care of them. That's actually so to say that it's certainly not something that we do now, but something that we're very interested in, is really going to be critical, going forward.
So how has it been in building those relationships with providers? Because I know sometimes building interdisciplinary collaborations can be tricky in the medical setting. So how has their openness been to working in this integrated model?
There's still plenty of work to do. I'm going to be honest. There's plenty of work to do. But one of the things that's been really helpful is for folks like me, but also folks on the front lines, meeting with people, talking with people, developing services that I think, and also, I've met with primary care physicians, and what we've really talked about is how doing this makes their job easier, how we can help their efficiency, how we can really help them take better care of all of their people, that has gone a long way. When we've been able to establish that we really are providing a service, a usable service, I think those types of things, but really it comes down to conversations. I mean, again, I mentioned this earlier, having a supportive leadership is critical. Jan has been really supportive. Dr. Tahir has been really supportive. Our administration across the board has been really supportive. That's helpful, but like any system, I mean, there are still challenges to get everybody on board, to communicate all of it effectively, to establish the right systems and structures. We still have a long way to go there, and would be willing to learn from others who maybe have done and kind of exceeded in that area. But again, meeting with people, talking with people, and really explaining the cost and benefit.
And as we look to wrap up, to confirm, referrals for the integrated care can come from the community, from individuals? Does it have to come via a medical provider?
Come from anywhere. Yep. People can come in and ask themselves, or yeah, it can come from anywhere.
Dr. Biscaro, thank you so much for sharing all that you have done to build this integrated care approach at St. Vincent, and we look forward to hearing more and seeing how it continues to grow. And for those on the call today, we do encourage you to follow up to learn more, and we will share some additional information in our follow-up email afterwards.